Okay, sir.
Going at what time?
You can go ahead, sir.
So, good evening, friends. Today we are going to discuss osteoarticular tuberculosis, and it is an extremely important topic. In fact, I have titled the first talk as Beware. Beware of everything about osteoarticular tuberculosis. So, 1 minute. I will stop the video so you can see the full screen. Beware, friends. India accounts for more than 1/4 TB burden as well as resistant cases. Extrapulmonary and osteoarticular TB are on the rise. Now, the problem is we orthopedic surgeons always felt that we are born and brought up with tuberculosis and we can diagnose it clinico-radiologically and treat appropriately. Unfortunately, things are changing significantly. And we as surgeons as well as societies need to do some innovative work. And 1 minute, I'll start my video. Neeraj, how do I start my video?
Sir, you have to नीचे रहता है ना start video left side पे left bottom में start video stop video. Yes. Which device are you using?
Thank you. So we need to coordinate with each other, with other specialties, other societies, philanthropic organizations for better patient care, collecting data to give guidelines as well as research. And I'll elaborate this during this talk. Coming back to our survey, about half of you are from a city which is less than 1 million and others are from a bigger city. These are the average number of TB patients that you see. Now, what is important is almost 60 to 70% have facility for different types of culture, whether it is LJ or midget. Now, the important question was, do you routinely start anti-TB drugs based on clinical and imaging studies? About 1/4 do start that. Some do culture studies when they are in doubt, while almost 50 or 60% as a rule get culture studies done, or rather get tissue diagnosis. Now, what is tissue diagnosis in your setup? About 70% said that culture and sensitivity constitute tissue diagnosis as far as they are concerned. That's a very important thing. Now, there are people who do not do TB culture as a rule. Unfortunately, almost 25% do not have facilities for TB culture. And some people feel that it is a useless thing because very often TB culture is negative. Almost 50% felt that resistant TB is on the rise. So based on this, I will make some important statements. First and foremost is, for decades, we have been hearing, reading that the diagnosis of osteoarticular TB in endemic areas is clinico-radiological. Every paper, every book keeps mentioning that it is a clinico-radiological diagnosis. What I strongly suggest that this term should be replaced with clinico-radiological impression. It is not a diagnosis. This is your impression, which is a starting point for initiation of investigations and not a starting point for initiation of anti-TB drugs by default. What we should do is try and get culture sensitivity in every case, because that is a complete diagnosis of TB. While some patients may qualify, they qualify for initiation of ATT if all the tests are negative, and then you are very strongly suspecting tuberculosis based on clinico-radiological or histopathology findings. So I agree that in some cases you need to do that. And lastly, and most important, is avoid empirical modification of non-respondent. If a patient is not responding, there is a great tendency amongst orthopedic surgeons just to start ofloxacillin, just to start streptomycin. Avoid that. Review the case completely. Obtain appropriate samples. Repeat appropriate studies. And most important, take a second opinion. Do not take non-respondents very casually. Now I take you back almost 55 years. This is Professor Dr. Mukhopadhyay, our Dr. John Mukhopadhyay's father. And he gave a Hunterian lecture to Royal College of Surgeons way back 1955. And based on tuberculosis, and his concluding remarks were, the struggle against tuberculous disease has been hard, long, and costly. But today, we appear to be on threshold of success. So in 1955, he was saying that now anti-TB drugs are introduced and we are very likely to win. We are very likely to win over this troublesome disease. And today, here we are, papers saying, is India ready for drug-resistant tuberculosis? Challenge of drug-resistant tuberculosis. And regretfully, no. Unfortunately, we are not prepared for this drug-resistant tuberculosis. So we need to answer some questions. Why has TB bounced back? Why has resistance increased? Why is it difficult to culture MTB? And that is why we keep talking of clinico-radiological diagnosis. So what is the current situation? And lastly, what are the general guidelines for diagnosis? So that then Dr. Aisha can take it from there. So why has TB bounced back? Or why has the resistance increased? No doubt it is the HIV epidemic which hit us and the world around 1990s onwards or 1980s onwards. Question is, if the problem is only because of HIV and the resistance is only because of HIV, do we have all the patients who are resistant HIV positive? No. Many of them or most of them are not HIV positive. So why should we say that HIV is responsible for resistance? I'll illustrate this with a case. 2018, that's 4 years ago, this 10-year-old girl presented with a large swelling of the ankle, fever, loss of weight, MRI highly suggestive of COX, and perfect clinico-radiological diagnosis. So obviously we said, no, we should have a tissue diagnosis, and therefore we did histopathology and we did culture. Now, when we did culture and sensitivity, we had a rude shock. We had a rude shock when we saw the sensitivity report. She was resistant to these 11 drugs. A 10-year-old girl, she was resistant to INH, rifampicin, etc., etc., etc. 10 different drugs. So what choice did we have? Dr. Udvadia, those days, this delamina, I cannot even pronounce that. It was not available in India. It had to be imported from Japan. Her father flew to Japan and brought that drug. She was being treated with that. The monthly cost of this medicine was almost 1,50,000 rupees. And she recovered quite well. Question is why? This 10-year-old girl, resistant to these 11 drugs, she was not immunocompromised, 100% not immunocompromised. She had never taken ATT in past. So there was no question of irregular treatment or inappropriate treatment. So why did she develop such troublesome resistance? Let's have a show of hands. Can anybody answer this? I'll stop sharing and let's have some discussion on this. Why is this patient resistant, has resistance to almost 11 drugs? Anyone? Can anyone answer? Let's have show of hands. Let's start with Chandu. Will you unmute?
Yes, sir.
Yeah. I'm starting from the top as I
Sir.
see the names. Any idea why this patient is such highly resistant?
No idea, sir.
Upadhyay, Akshay, Akshay, you there? Akshay, can you
Yes, sir.
unmute?
Yes, sir. I'm here.
Yes. Any idea? Anyone? Upadhyay, Suranjan Nag, Aisha, not Aisha Sunawala, of course. Angad, Nanda Kishore, Som Sundar, anyone. So it is.
Yeah, sir, Angad has raised his hand. Angad, can you unmute and talk?
Because the patients who are on AKT, they actually fall out of treatment. They don't take the treatment to its completion.
Right. So as I said, this patient had never taken ETT. That was the first time she presented to us, first time her culture was obtained, and first time she was in for an AKT.
She might have contracted TB from some other people who were patients and who did not carry out the treatment.
Perfect. So how many of you are aware of primary resistance and secondary resistance? Somebody has raised hand. So just raise your hands, whosoever is aware about primary resistance and secondary resistance or acquired resistance. It's not secondary, acquired resistance. So just raise your hands. And as I think who told us about she has acquired disease from somebody else. Just now I'm very poor at remembering names. I'm sorry. Angad said that. Angad said that, right?
Yes, sir.
That's a very, very important point he has made, that she possibly contracted the disease or got the disease from somebody who is resistant. So that is primary resistance. So I'll just go ahead. Can you see the screen now? Is the screen visible?
Yes, sir.
Yes, sir. Yes, sir. We can see it.
Yes, sir.
So I take you back to another paper about 15 years ago. And this was a huge study done in Mumbai. Maniyar et al. More than 8,600 TB patients HIV patients were screened. Majority of them had tuberculosis. And of the culture positive patients, almost 42% were resistant to TB, resistant to anti-TB drugs. So that means these people acted as epicenters because they were not isolated. Those days, nobody thought, even now, nobody isolates MDR patients or drug-resistant patients. So they were free to move around in the society. So they behaved as epicenters, infecting community at large. Now we know from our second MBBS days about the pathogenesis of TB. Almost all of us in India, almost 90%, have what is called primary complex, because we get TB germs in our lungs. If the immunity is reasonably good, they just remain as primary complex. If the immunity is low, not immunocompromised, but low immunity, you would get a full-blown disease. So if you get the disease from a patient who is already drug resistant, if you have good immunity, then they will develop a primary complex, but that also with resistant bacilli. And People who have low immunity, low vitamin D, not exposed to sunlight, malnourished, etc., they will have a full-blown disease with resistant bugs. So she contracted this from a patient who was highly drug resistant. And that is why the problem is cases of primary resistance are increasing in like this unfortunate patient. And that's a very, very scary situation. Therefore, we must diagnose TB as a whole. We must have a complete diagnosis of TB with drug sensitivity. Now, what are the difficulties involved? First and foremost, the culture yield is less, as many of you have said. Culture yield is less. Why is it less? Anyone? Why is, again, I'm going to stop sharing. Why is culturing MTB from osteoarticular area not as successful as culturing mycobacteria from lungs? Anyone? Anyone? Why it is difficult to get? Yes, getting a sample is a different story. But after getting a good sample, the culture yield often used to be less. Why?
Sir?
So I'll go ahead.
Oxygen,
Yes.
probability of oxygen, it is an oxygen dependent microorganism, sir.
Perfect.
So
Who is that? Who is that?
Sir, Srinivas here, sir.
Fantastic. Great. Great answer.
Thank you, sir.
So these are obligate aerobes in lungs. As they travel to osteoarticular areas, the oxygen concentration goes down. And as Srinivas rightly said, they do not get adequate oxygen. So they become facultative anaerobes. Therefore, they become posibacterial. They become less active. Their multiplication decreases. And therefore, the culture yield decreases. So we need to be exceedingly careful about collecting samples. That's the most important thing. And we have been stressing about samples time and again. So this, unfortunately, for years together, good response to ATT and poor culture yield led us to believe that A, culture yield is poor as shown in various studies. And second, as late as 2019, this paper from ISAO, 28 out of 37 patients were diagnosed by clinico-radiological imaging by MRI. So this continued for quite some time, that clinico-radiological is adequate. Yes, up to about 1980, 1985, 1990, this was reasonably good because patients who presented late with full-blown disease, it was reasonably easy to pick them up, and they almost all responded to anti-TB drugs, but there was nothing like resistance. Once MRI started coming in, we started trying to pick up these patients early. Same time, resistance started, and there was a problem. So how are there any publications stressing the importance of this, stressing the importance of establishing tissue diagnosis, ruling out mimics, and studies done in India? So this was our first paper, 2009, published in 2009, Diagnostic Solutions in a Disease Endemic Region. This was essentially a Bombay Orthopaedic Society and Hinduja study done in 2004 to 2007, sponsored by Hinduja by a generous grant of 7 lakhs those days, 2003. And what we did was we collected samples from all over Mumbai, all over Greater Mumbai. So over 28 months, 36 surgeons contributed to samples and most important clinical data of 93 patients. And what we found was patients who were about to be started on ATT or they were not responding. Almost 13% did not have tuberculosis. Many of them had pyogenic infections. There were so many other diagnoses. But the culture yield, in spite of such heterogeneous sample, we had no control over collecting sample. We had just given guidelines. We had given them culture containers and continued to hammer as to how to collect sample. So the midget yield was 58% and even LJ yield was pretty good. Another very important publication from Kapil and Abhay Nene, they collected or they went through their data of almost 20 years of 686 culture positive patients and realized that almost 16% were resistant to at least one drug. So it is vital that one needs to do culture sensitivity studies. Now it is very often, as I said, if the patient is not responding to ATT, our tendency is to start second line drugs or add two drugs, commonly ofloxacin and kanamycin, very commonly, or amikacin. That is what has been done. So we decided to have another project by Bombay Orthopaedic Society, which was fully sponsored by Bombay Orthopaedic Society. They gave a grant of almost 13 lakhs. And the paper published was Diagnosis and Management of Osteoarticular Tuberculosis, a drastic change in mindset needed. It is not enough to simply diagnose TB. So this project was done from 2010 to 2014. Again, we appealed to all BOS members to contribute samples as well as clinical data. Now, clinical data is very, very important because we need to correlate this. And of 89 patients enrolled who were not responding, what is important is they were not responding to anti-TB drugs. As much as 16 out of 89 did not have tuberculosis. They were just being treated as TB. Almost 50% had definite TB because they were culture positive TB, and of them 33 were resistant to at least one drug or other, and 21 had culture negative and histopathology positive. So how does one ensure a good tissue diagnosis and sensitivity pattern? And we rule out mimics. So the roadmap is a good clinico-radiological assessment. It's very, very important to go through MRI carefully, discuss with MRI consultants. Please go through Dr. Jain's articles on diagnosis of TB spine. Exceedingly good and important articles. Then discuss with a physician or ID consultant. Try and develop such friends who have interest in infectious diseases. And then we have been stressing this again and again: appropriate samples, appropriate container, transfer SAP, don't let them dry, and communicate with microbiologists and do all the tests. Now, people who do not have facilities for this, try and contact nearest district hospital. They may not have midget, MGIT, which is the latest thing that we are using, but they are very likely to have LZ. Almost everywhere today, LZ and gene expert facilities are available. So communicate with your district hospital, and I'm sure you will be able to make use of their facilities. So at least do LZ, if not midget. I will just elaborate this with some clinical scenarios as to why culture studies and tissue diagnosis is important. Now, this man presented to us in 2012. He was on ATT continuously for 5 years. 60 months he was on ATT because he was not responding, and intermittently for 9 years. I'm tracing his history. This is 1996. He had pain in the left elbow. He was operated and diagnosed as tuberculosis based on histopathology. Obviously, those days, hardly anyone was doing cultures. Started on ATT, he possibly defaulted. That was an important reason, possibly defaulted. Now, April 1998, the elbow lesion recurred. So again, exploration and arthrolysis was done, and they restarted anti-TB. This is 2002, again discharging sinus. Now you can see he has a bony ankylosis, he has osteolytic areas. So empirically, he was treated with Cifran, Ampiclox, and ATT. 2006, again debridement was done. Here you can see more osteolytic areas. Ofloxacin was started. 2007, you can see now he has multiple sequestra in addition to ankylosis, multiple areas of osteolysis. In addition to anti-TB drugs, he was started on these drugs empirically, levoflox, ethionamide, cycloserine, clarithromycin for some time. Again, it was only histopathology. So when he presented to us, as we included him in our project, remember all these patients were treated free as regards investigations were concerned. That means the clinical assessment by us, all the investigations, including CT or image-guided biopsies, and consultation by appropriate consultants was done free. Free manje BOS paid for that. So patients didn't have to pay anything. So this time, you can see by now, he has a significant destruction of humerus, multiple lytic areas. So we did debridement, histopathology, and culture, which grew Mycobacterium tuberculosis complex. So we had a complete diagnosis, and he was resistant to Isoniazid, rifampicin, pyrazinamide, ethambutol, streptomycin, all primary drugs. And he was put on these primary drugs time and again. So these were the susceptible drugs. Modification of ATT was done by infectious disease specialist. So for the first time in 16 years, after several surgical procedures, we went beyond simply diagnosing TB and could give appropriate treatment. So this is him in 2013, clinically absolutely fine. We continued this second line for 24 months. This is him in 2019, 7 years, totally asymptomatic. But remember, TB had the last laugh. This was a New Year's present for us. Unfortunately, he had recurrence at elbow. He had a new lesion developed over lower back. This is on the lower back and with same resistance pattern. So we have really not won over TB. Now I take you to another case scenario. As I said, 16 out of 89 patients were on anti-TB drugs who did not have TB. So this patient, a 37-year-old patient included in the project. She was on ATT for 6 months. She was in the project because she had pain in dorsal lumbar region. This was her old MRI when she presented to us. Possibility of early infective process is likely than degenerative process. Based on that, the orthopedic surgeon with pain, uncomfortable thing, raised ESR, imaging suggestive of infection, he started on ATT. 6 months down the line, she was not responding, so she came to us. Now she gave history of CA breast 3 years ago. We repeated the MRI, and it was highly suggestive of metastatic lesion. CT biopsy confirmed metastasis from CA breast, and unfortunately, we lost her. Another patient who was on ATT for 11 months, diagnosed as posterior element cox on MRI. Should we empirically step up ATT? Now, as I said, revisit the history, revisit the MRI, revisit other imaging studies. So MRI, the clinical thing was he was more uncomfortable at night. During the day, he was not very uncomfortable. The MRI consultant said that no, this is most unlikely to be TB. There is hardly any soft tissue. We'll do a CT, and that showed osteoid osteoma. He was relieved by radiofrequency ablation. Now, what is important is we compared the two studies, two projects of Bombay Orthopaedic Society, and realized that the resistance pattern has worsened significantly since previous study. In just 4 or 5 years, you can see the first study, there was no resistance to pyrazinamide that had grown to 80%. Ethambutol had doubled. Streptomycin had increased. Ethionamide doubled. Oflox and moxiflox, again, the resistance had increased significantly. And we had started getting resistant to amikacin and capreomycin, which was not there in previous studies. Now, I agree that these are very small numbers. Our numbers are not many. 90 cases of osteoarticular tuberculosis is hardly anything. But same thing has been noted in pulmonary tuberculosis. Exactly similar pattern. Now, this was a study published in 2015 where they compared resistance pattern from 2005-2007 to 2011-2013. And they realized that XDR had increased. XXDR, which was not there, has increased. Ofloxacin resistance has increased. Moxiflox resistance has increased. Ethionamide has more than doubled. And that means we are possibly going to pre-antibiotic era. Not only in pyogenic infections, but in tuberculosis infections. This was a hallmark paper by our friend and colleague, Dr. Zarir Udwadia, when he said totally drug-resistant TB. He published series of case report of 4 cases with total drug resistance. Now, unfortunately, it created a political storm. People said that you can't call it totally drug resistant. There are other drugs available. These are not the only 12 or 13 drugs that are available for TB. And this is not fair. Resistance to 12 drugs does not mean total drug resistance. Maybe the title could have been different, but no one can challenge that this represents an exceedingly dangerous situation. This needs a tremendous political will to correct it. And our National Planning Commission felt that we should eliminate TB by 2030. The mindset needs to be changed. We must address this. Now compare this with another study from Lancet. They have postulated that if there are no changes in tuberculosis management practices in India, the MDR would increase by 275%, and 85% of them will have primary resistance. So friends, we are dealing with an exceedingly dangerous situation. Now, do we have facilities pan-India for this? Yes. Remember, almost every district has gene expert, and now they are going to pyrosequencing also. There are more than 1,000 midget machines in India. And there are many, many more LZ facilities. Almost every district has LZ facilities. Now, what about green areas? What about non-endemic areas? So this was a review article by us with our friends from developed countries. Diagnosis of osteoarticular tuberculosis, perceptions, protocols, practices, and priorities in endemic and non-endemic areas. This was a paper by World Association Against Orthopaedics and Trauma, against infection in orthopedics and trauma, or WIOT. So we know that there is a problem in endemic areas. Now, what is happening in non-endemic areas? The patient load is less. Therefore, perception is poor. Very often samples are not sent for TB cultures because they don't even think about it. And this leads to diagnostic problems, delay in diagnosis. Several papers from green areas suggest two things. One is prevalence of TB and resistant TB is increasing significantly there. There is more delay in diagnosis of spinal as well as extraspinal tuberculosis. Paper from Netherlands. From Italy, you can see almost 8 to 10 months delay in diagnosis. Paper from United Kingdom of 31 patients, infected patients, and in as many as 7 patients, biopsy specimens were not sent for mycobacterium. They needed second biopsy, and then it was proved that they had tuberculosis. So they had to be reoperated. They did not even think that they needed investigations for MTB. So the problems are world over, and therefore it is recommended now, even in green areas, that samples are sent for MTB. And thus the guidelines that I suggested right at the beginning of this talk was published in this article as buyout views. The term clinico-radiological diagnosis be replaced with clinico-radiological impression. It is very important to have good clinico-radiological impression, as I showed you in 2 cases who were being treated as COX. It is a starting point for initiation of investigations, but not anti-TB by default. We should aim for complete diagnosis in every case. That is culture and sensitivity studies. Well, yes, some patients may qualify for ATT if all the tests are negative, but you are strongly suspecting TB. Avoid empirical modification in non-respondents. Remember, non-respondents is a big group. You must restart everything, restart the wheel. Lastly, in endemic areas, as I have discussed, but what is important is in non-endemic areas, the orthopedic surgeon should remember that there is a disease called osteoarticular tuberculosis. Friends, we must think global but act local. And I request all of you, each of you, to start this initiative, take initiative in addressing osteoarticular tuberculosis in particular and all infections in general. Thank you, friends. I'm open for questions. Any questions?
There aren't any in the chat box. If anyone wants to ask questions, you can unmute and ask.
Hello, sir. This is Akshay. I wanted to ask a question.
Yes, please.
Sir, many times we encounter in the OPD that a patient comes who has been already started with an empirical ATT and is not responding. So how to go about, should we stop the ATT for some days and then take a tissue biopsy, or should we immediately go for it? And how does the ATT which has been already started affect the results, sir, further results?
Correct. Very, very important question. Remember, if patient is not responding, that means the drugs that are going on are not acting.
Yes, sir.
Therefore, most of the times the culture becomes positive and you can start appropriate treatment. So if the culture gets positive in patients who are not responding, they are bound to have resistant TB. So as I said, don't immediately modify drugs. Don't immediately jump to surgery. Review the case in toto. Go back from day 1. Start taking proper history. Good radiology analysis. Go through all their reports. Find out whether they have taken medicines appropriately or not. And then develop a roadmap and get samples if need be. But do not stop anti-TB drugs.
Okay, sir.
Yeah.
So we'll have to ask the patient to keep continuing and then take a biopsy.
Yes, but then spend a lot of time with the patient and go through all this.
Okay, okay.
Yeah.
Thank you.
So if there are no more questions, Dr. Aditya, can you start? Have you stopped sharing?
Yes.
I think I've stopped sharing. Right?
Yes, you have. So in continuation with the question Dr. Akshay asked, should we take the shoulder case? Because that would
I think
answer.
so. Yeah. You think so? Okay.
Because that's a short case and
sure.
So the first talk given by Agashe sir has told us that the protocol is extremely important in tuberculosis as in pyogenic infections. So let's see how we manage this case based on the protocols, the history, the clues that we had. So this is a 15-month-old with a discharging sinus in the right shoulder the last 2 months. And the X-ray showed multiple lytic areas in the proximal humerus with some irregularity in the physis as well in the growth rate. Now we traced the history, we sat down in detail, spent some time. The mother gave the history. There was some shoulder pain 2 months back. X-ray and MRI at that time was suggestive of proximal humerus lytic lesions. So they were referred to the orthopedic oncosurgeon, Dr. Manish Agarwal, who, as per protocol, did a biopsy, an image-guided biopsy, which should be done in any lytic lesion, if image-guided or open. Your image-guided biopsy was done to differentiate between a tumor versus infection. The histopathology in that biopsy showed caseous granulomas. Again, important to note, both histopathology and the cultures were sent. The cultures grew pan-susceptible Mycobacterium tuberculosis. And the kid was started on first-line anti-tuberculosis therapy by the pediatrician. This is important because wherever possible, we must involve the physician or the pediatrician, even for first line, because there are a lot of things as orthopedic surgeons, we don't understand the drugs as much. It becomes a lot to take when side effects happen. In spite of following all of this protocol correctly, the kid developed a discharging sinus at 2 months with increasing pain. When he came to us, we then asked for an MRI, which clearly showed a lesion in the proximal humerus crossing the growth plate, and it had significantly increased compared to the previous MRI. So within 2 months of having treatment for a pan-susceptible mycobacterium, the lesion had increased. There was a discharging sinus. Dr. Akshay, would you want to take it? And give us your point of view as to why has this happened and what should we do now? Should we straight away start empirical second-line therapy? Should we explore? Should we increase the dose? Look at the dosage. What should we do?
No, sir. According to my knowledge, so first, whether it is culture proven, so it is already culture proven. Second, we have to make sure the compliance of the patient.
Correct. Which was compliant. They were compliant.
Okay, sir. If the next line would be to see whether the plasma levels of the drugs are normal. That is according to the in the therapeutic range. And if that is also not there, then we can think of re-exploring or doing or some other conditions like MSMT or something.
Correct. Perfect. I think that he's hit the nail on the head. And these are the things that should go through our mind. So whenever we face with a recurrence or persistent infection or something which is increased in spite of proper therapy, we should look at medico-surgical causes. Now that time we did not have rifampicin, serum rifampicin isoniazid levels. But what possibly was the cause, and we see this in a lot of cases, if the burden of infection is a lot, if there's an abscess, the AKT, even though adequate, which was as per the dosage for a 15-month-old, is inefficient because the antibiotics, the drugs cannot enter the area of infection. And we must try and reduce the burden of infection and make the anti-tuberculosis therapy more efficient. So that was the thinking we had, that it could possibly be a surgical cause. Sometimes there are sequestria which must be removed. So the plan was to debride. We took an incision excising the sinus. The proximal humerus, as expected, based on the MRI, was full of granulation tissue and pus, which was scraped. And we had to debride some of the physis since the infection was crossing the physis. Now, at this stage, we sent for all the tests, gene expert, histopathology, cultures. The gene expert came out to be positive with no rifampicin resistant. Histopathology again showed granulomas. First-line anti-tuberculosis therapy was continued, which was isoniazid, rifampicin, pyrazinamide, ethambutol. Now, the pediatrician felt that the rifampicin resistance was not seen, but by now, because of this persistent infection increase, there could possibly be some other drug which was resistant over the last 2 months. So empirically, they felt that adding moxifloxacin and cycloserine was justified in this case because an infection which has continued for 2 months without any improvement, even though it was pan susceptible, could have possibly developed resistance. Although gene expert showed rifampicin sensitive. So gene expert just tells us about rifampicin, the original gene expert. Now, as suspected by the pediatrician, the MGIT culture at 3 weeks showed resistance to pyrazinamide. So only one drug or monoresistant, as we call it, was resistant. All the others were sensitive. So pyrazinamide was stopped. The others were continued for about a year, and no grafting was done. The bones started consolidating. This was the 9-month X-ray. Clearly, the lytic area started filling up. Good range of movement. The sinus healed. There were no signs of infection. ESR had normalized. And this was at 5 years. The kid just come last year. Full range of movement. Could do external rotation, internal rotation. Absolutely active. And to our surprise, the X-ray looked absolutely normal. We in fact had to check the side, see whether it was the same. Absolutely normal. This is the progress of healing from pre-op to 9 months to 5 years. The physis had normalized, the metaphysis was absolutely normal, remodeling had happened. This was the lateral view. So what this case clearly shows us that whenever faced with a lytic area, especially in pediatric case, we must always biopsy, send for cultures and histopath. If worsened, look for medico-surgical causes, as Dr. Akshay clearly highlighted. Inadequate source control or a burden of infection could be the cause for persistent infection or a sequestrum. And if the antituberculous therapy is continued, some of the bacteria do develop resistance to some of the antituberculous drugs. Whenever we debride, again ask for all the tests and don't rely only on gene expert for the full sensitivity. Send for MGIT, look for 3-week and 6-week supports. And especially in pediatric patients, once we get a good clean bed with adequate medical therapy, the biology just takes over and functions are far beyond our expectations. So we took up that case in line with what Dr. Akshay had discussed.
Correct. Absolutely. I think very important learning point from this case is involve pediatricians. Don't think of modifying anti-TB drugs on your own. That is number one. Number two, if the patient is not responding, there is something wrong. Number three, very often we keep saying that treatment of osteoarticular TB is medical. Yes, it is important, but we need to decide when to operate. What are the indications for surgery? Any questions on this case?
No,
if there are no more questions, I will start sharing a case. So this was a middle-aged person, 62, presented on 26th October 2019. He had a discharge from right olecranon lateral aspect for 1 month. He had stiffness of elbow for 18 months. There was some surgery done of IND abscess over right olecranon 18 months ago. And then before he came to us, 4 days, that's why I'm putting dates, 14th October, 5 days prior to that, a swab culture from the sinus was taken, which had grown MSSA. And with that report, he came to us. So at present, he has a sinus and 2 healed incisions. He has a flexion deformity of about 30-40 degrees. Total of 50 to 60 degrees range of movement. Pronosupination was practically not there. This is the X-ray taken 5 months before presentation. You can see there is a large lytic area here. There is a defect in the cortex here. But unfortunately, no treatment was given. So this is him at presentation. The lytic area is increased significantly on both sides. And that's the blood tests were suggestive, highly suggestive of infection. MRI shows an extensive lesion. Can you see a large lesion here, large infective lesion going into radius ulna, in between radius and ulna, in between. Here you can see olecranon lytic area and a large infective lesion. Here you see significant synovial tissue in the posterior to the humerus, anteriorly, everywhere. So what is the plan of action? Start MSSA antibiotics, aspirate FNAC, mini incision biopsy, because if it turns out to be COX, then it is likely to respond to ATT. Or you would like to do a full exploration and debridement. And if it is TB, can you classify this? Can you give guidelines for management and prognosis? And naturally, this patient will have questions. Will I get full range of movement? Will I have pain? And will I be able to do activities of daily living? So there are two different things. One is, what are we planning to do? And number two, if it turns out to be COX, I'm not saying it is COX. If it turns out to be COX, then can you classify this and get some guidelines as to the treatment? I'll stop sharing here. And now this, I feel there'll be answers, there'll be questions, there'll be inputs. So please, let us start with Upadhyay. You there? Upadhyay, you there? If he's not there, Aisha. Aisha, can you hear us? Please unmute and give inputs. What would be your plan of action? Nanda Kishore, you are there? Or everybody is enjoying the Saturday evening by just joining?
Sir, exploration of the lesion is very important, sir, but the range of motion is again questionable, because there is a proximo-radial you can say synostosis has already taken place in the lesion. So the thorough exploration of the lesion, and again subjecting it to a histopathological examination and microbiological evaluation, that has to be done.
Anybody else? Anyone who would like to just do a small biopsy, and if it turns out to be TB, start on anti-TB drugs?
No, sir, even me, I would explore, completely debride, remove all the necrotic tissue, yes, as well as sequestrated bone, and then send for cultures and treat accordingly.
Correct. I totally agree, because the joint is significantly involved. Now, what are the guidelines? Are there any guidelines for management of elbow lesion? And is there any classification? Now, this is a paper I would request you all to read. Tuberculosis of the elbow, a clinico-radiological analysis by Dr. Mandeep Dhillon. This is 10 years old paper, but still extremely useful. So they retrospectively reviewed their 38 patients, 40 elbows over 14 years. Though a retrospective review, there are many learning points. This is the area that is involved. Most of them had olecranon or olecranon coronoid junction. So most of the time, elbow tuberculosis starts here in the olecranon. And then they followed Martini's classification and finally modified it. Now, in 1988, Martini has classified upper limb tuberculosis into 4 types. Now, something like this is used world over. Different grades or stages. First stage is synovial hypertrophy, no bony involvement. Last stage or stage 4 is gross destruction, subluxation, dislocation. So totally destroyed. In between, you have two stages. Stage 2 is extra-articular involvement, bone involved, extra-articular involvement. Like in elbow, it will be epicondyle or olecranon. And stage 3 is extra-articular involvement, which is threatening to burst into the joint, or intra-articular involvement. This is by far and large, almost every joint you will be able to classify like this and get guidelines for management. Now, Dr. Dhillon et al. Modified this as type 3 was broken into two. One was stage 3A, which is extra-articular, threatening to break into the joint, but it has not broken into the joint. And stage 3B, which is intra-articular involvement. Now, why is it so important? It gives significant guidelines for management and outcome. Because patient is bound to ask you, what am I likely to get? What would be my range of movement? So, number one is first and second type. That is, when joint is not involved, when the bone is not involved or it is extra-articular, can generally be treated with medicines. Once you have proved this as TB, then generally they respond to ATT, there is no need to operate. But stage 3 generally needs to be operated. Now, why have they differentiated into stage 3 and stage 3B? Look at this. Stage 3A, all patients had good result. By stage 3B, you can see that there is not a single good result. So, moment the joint gets involved, chances of getting a decent range of movement, painless joint, become much, much less. So they have warned that not only flexion extension, pronosupination is a problem. Only 17 patients out of these 40 or 38, whatever, had more than 90 degrees pronosupination. Only 23 elbows were painless. So type 1 and type 2 were painless. Rest, 13 patients had pain with stressful activities and 4 had residual disabling pain. So remember, we have to catch this early. So the indications for surgery are patients who are obviously not responding to chemotherapy for whatever reasons, whether it is type 1, type 2, stage 1, stage 2, does not matter. Number 2, stage 3A, when there is an extra-articular disease threatening to burst into the joint. This is one which has to be picked up early. Once you have an extra-articular disease, don't wait for ATT to act. Act surgically and debride that lesion. Because once it breaks into the joint, there would be trouble. Now remember, management of TB spine is different than extra-articular TB. Because TB spine, you need stability. Here we want mobility. That's the main difference between these two. So there, if you have fusion, there is no problem. In fact, you want fusion. Here you don't want fusion. Stage 3B, with still some preservation of the joint. In this case also, you need to debride well. Whatever joint is remaining should be preserved. I just shared that case of TB knee, where the lateral condyle was already involved, but you need to act at that time, debride the joint well, let ATT act, and then you are likely to have a reasonable range of movement. Now, as regards stage 4, the joint is already fired. Whatever surgery you do is for debridement or for addressing the ankylosis. So that's a major difference between spinal TB and extraspinal TB. Remember, we need to act early in this case. So therefore, this patient surely needs surgery, whether it is pyogenic or TB. Now, next question is, what incision do we take? He already has 2 incisions and 1 sinus. So we decided to include the lateral most incision and a sinus. So this was the incision. That's the olecranon, and that's the curved incision that we decided to take. We excised the sinus and previous incision, as you can see here. That was the sinus tract, which was leading to this defect in the olecranon, which was reasonably small. Here you can see that's a window in olecranon. And then once we made a good window, here you can see at the depth, thick granulation tissue, thick infective granulation tissue. So we went ahead and did synovectomy posterior as well as anteriorly. Histopathology was suggestive of Cox, so we started anti-TB drugs. He grew pan-sensitive TB, and therefore 4 drugs anti-TB were started. This is at 6 weeks and 3 weeks and 6 weeks. The incision wound healed primarily. That is the X-ray at 5 months. This is at 12 months after completing ATT. It's almost full pronation, but supination is just about more than 90 degrees. He has a decent flexion extension. If you remember, initially he had just about 90 degrees flexion. So he has almost full flexion now. So pretty good range of movement, can do everything as he used to do before all this. So remember, stiff elbow with osteolytic areas should prompt you for further imaging like MRI. Because if that was done 5 months before he presented to us, I think things could have been a little different. So this Martinez classification, you can say that can be used for almost all cases of extraspinal TB. Stage 1 is synovial hypertrophy, no bony involvement, can safely be treated with anti-TB drugs. Stage 4, gross destruction. In between, we have extraarticular bony involvement. Stage 3, we have extraarticular bony involvement threatening to break into the joint, or intraarticular involvement. So, general roadmap for peripheral joints is stage 1, generally conservative. Stage 2 can be conserved, but we need to think if it is coming near the joint, we must explore. Stage 3, must do surgery. You are likely to salvage the joint. Stage 4, it is impossible to preserve the joint by any kind of surgery. You need to either debride if there is persistent infection, or you need to excise the joint, or arthrodesis, or total joint replacement. But you cannot salvage the joint in stage 4. Stage 3 and sometimes stage 2, you must address and try and salvage the joint range of movement. Thank you, friends. Any questions?
May I ask you a question, sir?
Yes.
So we see a lot of bursitis, like olecranon bursitis, lateral malleolar bursitis, and most of the situations, some of them, at least more than 50% patients do not agree for surgery. So it raises a doubt, and then, okay, fine, you don't say you say it's benign, it's not going to have an aggressive course, don't do x-rays, they're fine, and leave them alone. This session today raises doubt whether we should at all leave them alone and insist on surgery and do an exploration, a radical exploration, and do a good tissue diagnosis whether we are missing out something. At least in some percentage of patients will definitely have what we are talking about.
So here your clinico-radiological impression is very, very important. Patients who are used to sitting cross-legged very often have these lateral malleolar bursitis. Patients who are used to sitting like this have olecranon bursitis. However, these can get secondarily infected, or they can threaten to get secondarily infected. In that case, don't just stop at aspiration, because they don't respond. That cavity is already formed. They get infected, or they are likely to get infected, do a generous exploration, excise the entire thing and send for all in the investigations. However, you can't obviously surgically address each and every case of bursitis. That's really not possible. So here your judgment comes in, and proper follow-up is important. So you have to tell them that today I am saying that I will conserve you because I feel that there is no infection. However, I would like to keep checking on you. If you develop any pain, when there is no pressure, there is little warmth, there is a small sinus, in that case, come to us immediately. Put it on paper that you have asked him to follow up with whenever all these things develop, and then address them.
Right, sir. Thank you.
Yeah. Okay, I have a doubt. See, this we have said that there's 4 stages, but first and fourth stage is very clear, but second and third stage of treatment is artificial, isn't it? Threatening to invade the joint. What are the signs that you are saying is eminently threatening? It's a cavity, it may break in. So, what is
based on MRI? Based on MRI, that was the.
Based on MRI, how can you qualify an MRI saying threatening to? Is there a guideline said 2 millimeter thickness left or 1 millimeter? Nothing.
No, it is subjective, sir.
So what I put down is that
so when you are in doubt, explore.
Sure, but then
when you are in doubt, when you have a lesion which does not have, which is likely to be near the joint, then it is best to explore.
Sure, but what I'm suggesting is that the distinction between stage 2 and stage 3 is artificial. So why don't you modify it, saying is that 2 and 3 is only 2. Is either 1 synovial, if it is affected, it is 2, go ahead and do it. If it is already destroyed, you will have to still do something about it, but don't promise any movement to the patient. So this 2 and 3 and then 3A and 3B is more or less artificial, just adding a paper to your name, that kind of stuff.
No, but I felt it did give guidelines to explain to the patient that,
sure,
unless I operate, you might go to stage 3B, it will burst into the joint, so I must operate. If it bursts into the joint, then you are not likely to have good results.
Sure.
So this just gives basically any classification gives you general guidelines. Finally, we have to use our own sense. This is nothing cut and.
Yeah, this is an opportunity for you to modify that martini and
I think sometimes in future.
Make it martini agashi.
Thank you, sir. Thank you for your good wishes. So if there are no questions, I think let's go to the case by Dr. Aditya.
Should we take that case? Yeah. Go ahead.
Sir, in stage 4 martini, when the joint is involved, the joint is already, the articular cartilage is eroded. So when exactly do we go ahead and do a arthrodesis, sir? So in the first surgery during debridement itself, or later, if later, so how many days later, like what is the guidelines for it?
Generally here, the joint is totally destroyed.
Yes,
there is no point in trying to salvage the joint, number 1. Number 2, once you have decided to arthrodesis, the best thing would be excise the bone in such a way that you go to the decent bone and excise it in toto, and then do arthrodesis.
In the same sitting, the first sitting itself, sir.
First sitting, you may not do arthrodesis. I think the next case by Dr. Menon will explain the how we can do, and then we will come back to this question.
Okay, sir.
It is exactly similar case. Exactly similar case.
Before Dr. Menon starts, can I ask a question regarding the arthrodesis and the replacement controversy? See, there are certain joints where we want the movement, especially elbow and the hip. Knee, we would accept an arthrodesis to a large extent, but hip, we would like to, do a replacement. And similarly, elbow, if the patient can afford, and fit enough, etc. Now, what is the timeline between finishing your chemotherapy, doing a reasonable good debridement, getting a disease-free joint, and then doing an arthroplasty? So what would be the timeline expectation in a hip and an elbow specifically?
Very, very important question. Now, things have been changing drastically. Good old days, people would wait for 5 years. It all started with waiting for 3 to 4 or 5 years before doing a replacement. Then slowly it came down to 2 years. Then people realized that they have operated with a presumptive diagnosis of osteoarthritis, and it has turned out to be TB. And since they have excised everything, in about 3 weeks' time or 4 weeks' time, they got the culture report, anti-TB drugs were started, and many of these patients started improving well, or many of them had good results. So now there are many people who believe that there is really no point in waiting for finishing anti-TB drugs. Many people have started doing replacement early. There's a paper by Dr. Bhosle, which I'll share with you, 50 cases of total hip replacement done during active phase. In about a month or two, he has been doing total hip replacement and has got pretty good results and has a good follow-up. And there are many papers in literature who have started, the paradigm is changing. So more and more people would address these in just 1 or 2 months or 3 months.
If I can
then
continue on that.
Very, very aggressive as regards debridement is concerned.
But personally, I would be very scared to do that.
Yeah, agree,
and more so because failure of treatment and then resistance, drug resistance. I have had one patient spine who had an INH resistance recently, just about 9 months. It's been on chemotherapy now. So I'll be really scared to do that. I understand logic behind it, but
I totally agree with you.
Of my teachers,
I will also add, sorry, go ahead.
Yeah, that's also, please carry on.
So I will also add that I will refrain from doing joint replacement in resistant cases. So I will establish a complete diagnosis. If it is pan-sensitive, then I would, if you ask my opinion, I'm just quoting from literature. I had quoted from literature. If you ask my opinion, I would always do it in only drug-sensitive cases. And I would possibly wait for at least 6 months before doing a joint replacement. 6 months of excellent response, and then think of joint replacement. I will not do it before that.
That would be the most judicious way of looking at it, sir.
Yeah.
Thank you.
Yeah. Hello?
Yes, go ahead.
I would agree with that, sir, because although TB doesn't form a biofilm, it does cause osteolysis. So especially in multi-drug resistant, we should be very wary of putting in a joint because it will loosen out if the response is not good. So it's 8:15. So should I quickly take the foot case and then Dr. Aisha can continue?
Yes. You start with the foot case because it will answer questions.
So this is a patient with TB of the foot with a delayed presentation. She was a 32-year-old female with pain in the foot since 2 years before coming to us. Initially, somebody had suspected a fracture because invariably all these infected patients say that they've had some trauma and attribute that pain and swelling to the trauma, which generally if you look at the history, the trauma would happen, there would be an asymptomatic period of weeks to months and then they get that pain. Subsequently, an MRI was done because the pain continued, which showed some lesion in the calcaneum. Elsewhere, biopsy was done, which was inconclusive. The swelling and pain persisted, took NSAIDs for 1.5 years, kept on increasing. Again, a repeat MRI was done, which was reported as a synovial sarcoma involving the navicular and talus. Correctly, they went to, this is the T1. The previous one was the T1 where bone is white and abnormal tissue is black. T2 is exactly the opposite where bone is black and abnormal tissue is white. It stands out. Correctly, they went to Dr. Manish Agarwal, the orthopedic oncosurgeon, asked for a USG guided biopsy, which showed caseous granulomas. And then the patient was referred to us with this report. Now, this is a presentation 2 years after the onset of pain. after the onset of symptoms. There was pain, there was swelling medially and dorsally. Patient was finding it difficult to walk. You can clearly see the biopsy site there. X-ray showed gross destruction of the navicular and the talar head. I mean, there was practically no talus. It had just ballooned out, and this is why somebody had thought of a tumor, because to see this kind of an aggressive picture with TB is very, we see it in very late stages. So we planned for an excision or for a debridement because of the extent of infection, which included the biopsy site. So we took a curvilinear incision along the biopsy site, excised that. The tendons and neurovascular structures were lifted together with a gauze piece rolled around it. It was elevated subperiosteally, and that was a defect, which you can clearly see with the infected granulation tissue, which is excised. I mean, what we try and do is go around the lesion along with the necrotic bone, try and take it out as one bulk, because if you take it out piecemeal, it becomes difficult to identify. So there's a very clear delineation between abnormal and normal, and biology automatically starts separating it. And that's a defect which was left after cleaning out the removing the entire tissue with the navicular and talar head excised. And this was the defect. There was obviously no navicular. Talar head was excised. And that is what we had to do. Gene expert was positive. Rifampicin resistance not detected. Started on first line activity. Isoniazid, rifampicin, ethambutol, pyrizinamide. Histopathology showed caseous granulomas. And these were Dr. Aisha's notes. Appropriate dosage as per the weight was given. And this was at 3 weeks. MGIT showed pan-susceptible Mycobacterium tuberculosis. Now, what is important to note is the minute the patient comes up with a positive Mycobacterium tuberculosis complex report, we are presented with a sheet which asks us for a drug sensitivity. Now, we can ask for just first line, we can ask for second line, we can ask for everything. What we do as a practice, although it is expensive, we ask for all 14 drugs, first and second line, simply because the incidence of primary resistance, as Sir has shown before, has significantly increased. So the patient, although on gene expert is rifampicin sensitive, may have iron H mono resistance or a combination of 2 or 3 drugs. So that is why we invariably ask for all 14 drugs, because if we ask for first line only and then we realize 1 or 2 are resistant, then again we have to ask for the second line. So that's wasting more time. So in one shot, we ask for everything. In this patient, everything was susceptible. Now, I would want to open it for a discussion here. This is the X-ray, the gap there. What do we do? Do we leave it as is, just continue VKT, or should we do something? Would somebody want to opine on this? Dr. Suranjan? Yes. Yeah. Please.
Yeah. I think this would need a midfoot fusion. Definitely will go for a midfoot fusion. You seem to have good bone on calcaneum as well as the midfoot, but if it is sensitive enough, the disease is controlled, you can actually go ahead and do a midfoot fusion straight away once your initial wound is healed. So wait for about 2-3 weeks, let the initial wound heal, start on ATD, maybe 4 weeks, and then go keep it non-weight bearing, and then go ahead for a midfoot fusion. That would be my plan. In this meanwhile, Dr. Menon, can I share a small short case which I have operated just 2 weeks back? Very similar one. And this gentleman had some swelling for the last 7 years, and somebody had reported mesothelioma. And when I went in, did a large excision, similarly as you had, taken the specimen toto. I'll share the pictures later on. And the biopsy is still awaited. It is not a tumor, and that's very strange. Somehow the sample sent for bacteriology was lost in the process. Something went wrong there. I was doing in a very different hospital. Anyway, so that's a similar situation which I faced just 2 weeks back. Anyway, please proceed.
Correct. Perfect. So again, asking for biopsy, I mean, histopath and cultures, both are important.
Yeah.
So how would you want to fuse this, Dr. Suranjan? Using allograft, autograft?
I would use autograft. I don't have access to allograft, number one. If I have, then that would have been a different scenario. Autograft would be good. I would use iliacrest strut graft, tricortical graft. And since the ankle joint is good, the subtalar joint does not look that involved. We'll try to preserve that. and would like to achieve a calcaneocuboid and a talonavicular sort of a fusion. So it would be something to keep a little bit of jog of movement in the subtalar joint and full movement in the ankle joint. So sparing metals over there, putting a lot of graft. An iliac strut graft is something would do good.
Perfect. I think that's the correct way to look at it, because as we would expect with a bone defect, the forefoot would start shortening, it would start collapsing, and that is something that we don't want, because the arch collapses, the biomechanics change. It would ultimately lead to a painful arthritis across the various joints. So we decided, as discussed by Dr. Suranjan, that we re-explored thin excision of the scar, made sure there's no infection, even sent samples even at that stage, which turned out to be negative later. Bone ends were freshened. We used a laminar spreader to regain the foot length. Measurements were taken with this spread out graft. Then took tricortical iliac crest graft, a single big piece, no slivers, a little bigger than the defect. The traction was maintained, laminar spreader was kept in, and then the graft was impacted inside between the talus and the cuneiform. So we didn't decide to touch the calcaneocuboid because that was virgin. Similarly with subtalar, so the minute we opened this defect, the talus and the cuneiforms were exposed. We freshened both sides, impacted the graft, and as soon as we impacted it, we released the traction and the laminar spreader, and it just collapsed, and it was auto-stabilized. I mean, it has to be a perfect fit. So K-wires were put in to hold the graft, and before we put in the wires, this is what we check, that the graft has to be absolutely stable on its own. Because if it's a loose graft only on wires, it will ultimately loosen out and not help with the arthrodesis. So this was the post-op X-ray. Length of foot was achieved. Clearly, you can see the gap between the talus and cuneiform has increased. This was 4 months. It had clearly consolidated. Removed the wires. This is 1 year, completely healed. Anti-tuberculosis therapy was stopped. So we give AKT for about a year in fan susceptible cases, and 18 to 24 months for second line. Second line would depend on the clinical radiological. There's no real guideline, but at least 18 to 24 months. This is the clinical image. So what this case shows us is early diagnosis is important to prevent gross destruction. Always biopsy. Debride till healthy bones. In mid-foot defects, try and lengthen out the tissues to prevent a collapse. Use structural grafts slightly bigger than the defect. Impact them. Make sure they're auto-stable. And fix them with wires temporarily, which you can take off later. So it's like a partial arthrodesis done within the foot, keeping the other joints open.
Thank you. Thank you. Great case.
Thank you.
Yeah.
Thank you.
Any questions?
Yes. I have one. Why does the laboratory ask you whether you should test for 6 drugs, 9 drugs, or 14 drugs? Is it a choice whether you want the drink shaken or stirred? I mean, if 14 drugs are available, they should tell us 14 drugs.
Money,
Why
sir.
give us a choice and then say whether you want this or you don't want? You must tell your department of bacteriology not to give choices which are not very welcome.
So this is a universal thing. Basically, because of money,
if it is not correct,
it's expensive. Let me. You ask for 4 drugs. If they are all susceptible, then you don't have to do second line drugs. So it's a compromise. I totally agree with you. But then people always think of money.
Hello, sir.
I would say let the Department of Bacteriology not think of money and do the best for the patient. When you open a surgery, do you think of money or you think of curing the patient? When surgeon has already committed the money, then you go and say, no, I had to do extra work, so I'm going to charge you extra. That doesn't happen. So when there is a culture, do the whole lot. 14 drugs are available, give us 14 drugs. Charge whatever you want to charge. But don't give us this devil's choice. It's very difficult to say, and it's also tempting to say, I'll spend less. Of course, it is true. Who's going to suffer ultimately? The patient, isn't it? So why give this such choice? Just a thought.
Anyway,
Dr. Thakur?
all the laboratories follow that, sir.
I can speak for Hinduja Laboratory.
Yeah, tell me.
We don't cater only to a private setup. So the Hinduja Laboratory is part of the government RNTCP setup. And this is a requirement of the government RNTCP where you have to have multiple choices for different sets of patients, pulmonary, extra pulmonary, what tests you'll do first, what you'll do next. Failing patients will have a different regimen. So it's easy for us in the private setup to subject everybody to a 14 DST because they're anyway paying for surgery and medication and everything else in a private setup. But it works differently with the government. So these are government stipulations and norms that we have to adhere to on our reporting.
Thank you, Aisha. Thanks.
Hello, sir. Can I ask, sir?
Yeah.
Can I ask, instead of 2 months, can I do the fusion at 2 weeks of anti-TB treatment?
Dr. Menon, you would like to take this question? Okay. I would rather wait for 2 months because then I know the clinical response. I'm reasonably happy with the clinical response, and then I would like to go ahead with fusion. 2 weeks would be too early.
Okay, sir.
Because the important point, Dr. Lustra, is we get the cultures at 3 weeks if you're lucky. If not, then at 6 weeks. And then we know the resistance pattern. And God forbid, if it's culture negative, then it will be totally on the clinical response. So we've started empirical first line. If the cultures are negative, we continue first line. We see if the patient is improving. Then we go ahead for a fusion. If the patient doesn't improve, then we may have to start either Rehabilitate or start on empirical second line. So these are the guidelines that you must use before attempting any fusion in any case, although tuberculosis doesn't form a biofilm, but it does cause osteolysis and destruction.
Okay, sir.
So as a rule, all the reconstructive procedures to be done only after culture studies are available and only when clinically and radiologically patient is not deteriorating. Am I right, Dr. Menon?
Yes, sir. Perfect.
Thank you, sir. Thank you, sir.
I think Suranjan wanted to present a case, short case. Suranjan?
No, sir, I don't.
He said he'll add it on the group.
You
I'll
just want
okay. Or any else next model, I'll give it, sir.
Okay, sure. Dr. Aisha, it's our pleasure to welcome Dr. Aisha. She has already, of course, given you a fantastic talk about 1.5 months ago. So, Aisha, please go ahead.
Sure. I'll start right away. I'll just share my screen.
Can I ask a question while Dr. Aisha is sharing the screen?
Sure, please go ahead.
With the other pathogenic organisms, we get an MIC, but when we come to tuberculosis, we just get whether it's sensitive or not sensitive. And how do we interpret that result? And why do we do so?
So because of the slow growth of tuberculosis, we can't judge it on the basis of an MIC, the way it's done in other bacteria, because of certain technical issues. The TB bacilli and the drugs are judged, the susceptibility of the drugs are based on a particular critical value, critical concentration. All right. So it may not be called MIC, but if you delve deeper into it and you talk to your lab, they will give you the critical concentration of each drug on the basis of which they gave you a sensitive or resistant for a particular drug. That critical concentration is based on an epidemiological cutoff value. That's probably a talk for another day. But
thank you. That was enough for us. But it was a good starting point. MICs were something which we never looked at. Your earlier talk actually has raised this question. So once a talk raises more questions, it's a good talk. So thank you.
Thanks. So I'm going to start with a case that's very similar to one that Dr. Aditya presented a little earlier. And I'll put in a little point there that Dr. Aditya even asked me to share with you, but I'm going to sort of take off with this case to highlight certain important principles of anti-tubercular treatment as a little recap and review to what we've actually been through. So this was a 32-year-old housewife who presented to us in August 2000, presented elsewhere in August 2017 with lower back pain, evening rise of temperature, 8 kg weight loss. So really the perfect sort of recipe, everything that points to TB. And routine investigations were only remarkable for the elevated ESR. You can see the spondylodiscitis over here on the MRI, abscess, paravertebral abscess. CT guided pulse aspiration was done and a gene expert detected MTB. RIF resistance was not detected and she was started elsewhere on the fixed drug AKT4 combination. So this comes as a fixed drug kit, which is given in even the government setups. Her fixed drug kit consisted of 450 milligrams of rifampicin, 300 milligrams of isoniazid, 800 milligrams of ethambutol, and 1.5 grams of pyrazinamide. Her weight was 55 kgs. Her fever resolved on the above treatment. She gained 2 kgs in weight. She had persistent pain and purulent discharge, which continued from the aspiration site, but she said that there was some improvement in the pain. However, 2 months later, when the intensive phase was over and the pyrazinamide was stopped, her pain and swelling in the right flank gradually increased. She lost 3 kgs in weight. And an MRI, which was repeated in December 2017, showed an actual increase in the size of the paravertebral soft tissue abscess, bilateral psoas abscesses, which we can see here. And this is something that we see very often. When I mean this is something we see, I mean patients who are doing well and then suddenly start worsening after the intensive phase when the pyrazinamide is stopped. So now I'm going to throw this open to discussion. What would you do at this stage? Would you start her on streptomycin or levofloxacin? Would you add that to the first line AKT regimen? Remember that she had an expert MTB RIF which was sensitive. You start a full second line antitubercular treatment. Do you want to surgically debride her and reduce the burden of the disease? Do you want to repeat biopsy and rule out resistance or anything else?
I would go for 3 and 4 together.
Okay.
There is pus has to come out.
Mm-hmm.
Whatever is not responding has to be reinvestigated. And there must be other factors what might be causing, apart from our resistance, drug resistance and inadequate debridement, there might be a third or fourth factor which is contributing to this. She might be a diabetic or recently diagnosed diabetic, not controlled, or any other factors which might be, should be considered.
Absolutely, I agree with you entirely. A lot of other factors that need to be considered. Anyone else? Any other point of view?
I would suggest we start second line of drugs because the initial the intensive phase has already been dealt with, and I had recently gone through some articles where they said that even in continuation phase, if there is some deterioration, not deterioration exactly, but even if the trend is not upward, in absence of neurodeficit, we can still continue drugs. So I think in that line, I'll say we'll go on and start second line of drugs in absence of any neurodeficit existing or any de novo development of any neurodeficit in the person.
Okay.
Would like to add one more point, Dr. Aisha.
Mm-hmm.
I think you mentioned weight was 55 kgs.
That's right.
Was rifampicin dosage adequate? You know, the government has got, the RNTCP program has got, according to the weights, the slabs, and I don't think they have a 450 rifampicin. They've got, I know it comes in a FDC, and then you have to add on either 2 tablets or 3 tablets. Was the drug which the dose that she was getting, was it adequate for her? That needs to be reconsidered once again.
That's the reason why I actually introduced that point with her weight and everything. One of the FDCs do come as a 450 and the other one comes as 600. And then you can add, as you said. But we'll come to that. That's an interesting, or that's, you sort of hit the nail on the head over there. Dr. Aisha, does it bother you that you want to start second line TB treatment on someone who had of course, we don't have a full midget culture, but you definitely have a gene expert that showed us rifampicin resistance. And we do understand that when we say start second line AKT, we are really subjecting somebody to multiple toxic drugs for a period of 18 to 24 months. And once we label them as drug-resistant TB, it becomes, it just becomes something that they have to live with for the next 2 years. So we're a little cautious when we do that. And I'll show you through this case, what we found out. So this patient actually underwent a sonography-guided aspiration of the abscess once again, all right? And this was done primarily to review the diagnosis. So what are the options that you have? And I'm sure you all know this. I'm just going to quickly take you through it. That the options we have are, we have the gene expert, which tells us only about whether we have TB or not and whether we have RIF resistance. And it gives us this information in 24 hours. We have the line probe assay, which can give us information on rifampicin, isoniazid, aminoglycoside, and fluoroquinolones. So 2 of the most important first line drugs and 2 of the most important second line drugs. And it gives us this information in about 72 hours. It's not an esoteric test. It's done everywhere in all the government setups. Line probe assay is now an accepted norm. We have histopathology that's available to most of us, as seen in your survey. And that gives us an idea of granular matters versus non-granular matters in about 72 to 96 hours. And finally, we have a TB midget culture, which is still the gold standard for diagnosis of active TB. And why have I put that word active TB? Because all the other tests, the gene expert, the line probe assay, now the new pyrosequencing, the new gene expert XDR, all these tests are molecular genotype tests. They cannot distinguish between dead bacilli and live actively replicating bacilli. So the TB midget culture is still indisputably the gold standard for active TB. And it gives us the downside of this is that it takes 3 to 6 weeks, if at all it's positive, to give us a report. Once it's isolated, once the MTB is isolated 3 or 6 weeks later, it still takes another 10 or 15 days for them to do the drug susceptibility test. And that's just the nature of the organism. So that really is a disadvantage over here and one that we are still to overcome. So this was the same patient's TB midget identification, and you can see this is how the report looks. We have acid-fast bacilli which were present. We have an MTB complex isolated, and we have this Nikshe ID. I'm sure you all have sort of seen your reports, and all your TB patients have a Nikshe ID. This is a government initiative and the first of its kind in our country. The word Nikshe, Sherog is TB, Nikshe is eradicate TB. So the Nikshe ID was made with the intent to provide universal access to the patient's reports and information. It's like the Aadhaar card for the TB patient. You insert their Nikshe ID into the government system and you will get all their reports, you will get all their latest information and everything. And even if these patients are being treated privately, all my patients report to me that they get frequent phone calls from government authorities asking them what medication they're on, how many months they've completed and everything. So it becomes the hospital, the labs and the doctor's prerogative to ensure that the patient has a Nikshe ID and that they are part of this government program, surveillance program and monitoring program. Okay, so this is what I was talking to Dr. Thakur about, and I think Aditya has also already been through it. Several reasons why, even sometimes when I'm quite certain that a patient has, sensitive TB, I may ask for a 14-drug DST pattern is because in a lot of patients, especially ones with comorbidities, elderly, or many other medications, they develop severe intolerance to first-line drugs, and I'm left with little choice but to use drugs from the second line. By and large, these drugs do come sensitive, but we do have the odd cases where we have odd resistance patterns. And in patients who can afford it, I always ask for a 14-drug DST. They've already spent so much. They're going to spend so much in the course of their treatment, so I don't compromise on this. But we have patients now who have undergone a pyrosequencing and they've come fully sensitive. We have patients now who've undergone expert XDR, which is the cutting edge expert test now, which gives us again immediate information about rifampicin, sensitivity, INH, ethambutol, and everything. And all these drugs are sort of available to us in a day or two, and we may not need the 14-drug DST package. And in these patients, I would go with just simple DST. But they're few and far between. Mostly we ask for the 14-drug package. So we've discussed this point, and I'm just going to elaborate on it in a little more detail. Clinical deterioration despite evidence of susceptibility. What are the possibilities? All right, so we have susceptibility over here, which was proven earlier, and we still have clinical deterioration. I think you all have been sort of gone through it. I'm just going to raise a couple of more points that were probably not raised. And if we were to start with inadequate dose, which I think Dr. Das just pointed out, inadequate dosing for weight, poor adherence to ATT, these are questions these are dialogues you need to have with your patient who presents with this, and you cannot do away with an intense dialogue into these factors. Is this a paradoxical response? Often we see patients clinically improving, but there's a radiological worsening, especially with spinal corks. Resistant subpopulations of TB? Yes. In the recent past, I would say in the last 6 months, I've probably had up to between 5 and 10 patients who've had 2 different populations of TB isolated from 2 different parts of the body. So a susceptible TB in one part and a resistant TB in one part, or 2 different populations from the same lymph node. So even that is possible. Inadequate serum levels of anti-tubercular drugs, somebody pointed out earlier, probably due to poor absorption, probably due to drug interactions with other medications that these patients are on, and of course, suboptimal drug penetration into extrapulmonary sites. We must understand that the dose of the drugs, the standard dosing that has been advised is based on pulmonary TB. And we are only extrapolating from pulmonary TB to the extrapulmonary sites without any real information as to whether that dose is adequate for bone, for CNS, for other difficult to reach sites. So I wanted to point out once again the importance of the first line drugs in susceptible TB and why it could be a grave error to actually use second line drugs when you have first line susceptibility, because really these drugs do remain the standard of care and the best possible drugs for first line for sensitive TB. So if we remember the story of the hare and the tortoise, rifampicin is akin to this tortoise, wherein it's active against both the actively growing and the non-growing TB bacilli. It works slowly, it works gradually, but it works persistently throughout the period of treatment, and it has this sterilizing activity on persisters. So the reason why we can get away with 6 months or 9 months of treatment, especially for pulmonary TB, is because of rifampicin. And often in patients in whom we can't use rifampicin, we choose to prolong the duration of treatment to some extent. We now have studies suggesting that standard dosing of 10 milligram per kilogram may be suboptimal and contribute to the emergence of drug-resistant TB, especially for TB meningitis. So studies done in TB meningitis have shown doses from 12.5 to 35 milligrams per kg and found that these are safe and efficacious in TBM. I'll be honest, I've never used more than 15 milligrams per kilogram, but apparently these have found several studies from across the world showing safety, showing efficacy, showing superiority to the lower doses for TB meningitis. Not enough work done on osteoarticular TB in this area. But perhaps we would need to extrapolate this to other extrapulmonary sites as well, drawing the same analogy. And isoniazid, on the other hand, is like this hair in the same story. Rapidly bactericidal, it's really a quick killer. It's the most important drug in the intensive phase, and one that we should always sort of, make sure that it's there in the intensive phase. That's because it's active against both the intracellular as well as the extracellular Mycobacterium tuberculosis. One asks that if it's really a rapid killer and it's working, mostly against the growing tubercular bacilli and not active against the non-replicative bacilli, is it really required for the entire period of treatment? It is such a strongly bactericidal drug and so important in the armamentarium that even if we have to do without rifampicin, we try to ensure that isoniazid is always there. One, throughout the intensive phase, and two, because it acts both intracellularly and extracellularly, its penetration into most places is excellent. So it's really a drug we can't do away with. What about ethambutol? Ethambutol really is just a companion drug. It enhances the effect of the companion drugs and it prevents resistance in them. Yeah, so it just augments their function. Pyrazinamide's key characteristic is its ability to inhibit bacilli that are in a sort of semi-dormant state, especially when they're residing in acidic environments like abscesses and pus. And that's why I pointed out earlier that when pyrazinamide is taken out of the intensive phase at 2 months, it is such an important drug for its penetration into pus and acidic environments that's when you see most patients who clinically deteriorate, who radiologically worsen and come to you. And there is now a strong recommendation even in tuberculous meningitis, in cox spine, for probably prolonging the use beyond the intensive phase, especially in patients who have tuberculomas and large abscesses. What about drugs like streptomycin, ofloxacin, levofloxacin? A lot of us, even as per our survey, have sort of mentioned that we throw these in as first-line therapy, or perhaps when you think a patient is not doing well enough, like this lady is. Streptomycin has now been considered it's considered obsolete. It's found to be sort of mostly ineffective and not to be used, and certainly not part of the first-line regimen. Ofloxacin, again, has been removed from the tubercular armamentarium. Levofloxacin remains a very powerful and important second-line drug. And that goes without saying that a single drug or even 2 drugs are tricky to add to a failing regimen. Yeah. If we strongly suspect resistance, one needs to move to a complete second-line therapy. But starting 1 or 2 drugs is probably it's detrimental and counterproductive. Yeah. So streptomycin out, ofloxacin out, levofloxacin never alone, and part of a second-line treatment regimen. So if we were to come back to our case, her rifampicin and INH levels were tested. Now we have the possibility to do this, and we have been using it, and it's really given us great insight into some of our patients' problems. So we did her serum levels and her pus levels simultaneously 2 hours after taking the rifampicin and INH dose. Of course, it doesn't matter in the pus, but it matters in the serum. And you can see that both the rifampicin and the INH levels were quite low. Rifampicin was abysmally low, 0.5 when the normal is between therapeutic ranges 8 to 25. INH also on the low level of normal. In pus, rifampicin was undetectable, just 1.5 in INH. We don't know what the normal value should be, but we do this because we're just trying to gain more information about it. Her TB midget culture showed sensitivity to all first-line drugs when it came in. So she was susceptible TB all along. She was restarted on rifampicin, INH, ethambutol, and pyrazinamide again. Her rifampicin was increased to 600 milligrams, which was about 12 milligrams per kilogram for her weight on an empty stomach taken alone. Isoniazid was increased to 450 milligrams 2 hours after breakfast. This is something that we have found through our drug levels, that when you give rifampicin and isoniazid together on an empty stomach, in the formulation that it's very often given as Arsenex, we find that the rifampicin levels are lower in the combination regimen than if you give rifampicin and isoniazid alone at an interval of fasting and isoniazid 2 hours after breakfast. So if we really want to optimize the levels of rifampicin especially, it should be given alone, fasting, followed by isoniazid 2 hours after breakfast. And that's what we did with this lady. We repeated her serum levels after optimization, and you can see the difference. It will be just that 150 milligrams more and taking it alone before breakfast. And similarly for the INH levels. She had complete clinical and radiological response on follow-up at 1 year. This is something that I do routinely, and I have encouraged my colleagues and fellows to do. When we start somebody on anti-tubercular treatment, we give them a sheet like this, which gives them information about the anti-tubercular drugs, because you have to understand that this is something that they're going to be on for several months, and with the second line drugs for several years. So they have to be educated and empowered to take a decision about their drugs. We discuss the common side effects and the serious side effects, and we give them a sheet like this to keep with them with our contact details. And we tell them that if they do sort of experience any of the serious side effects, they need to come back to us or get in touch with us even without an appointment. Or if there's any doubt, especially with amikacin, when you're using an aminoglycoside injection, if there is any symptom of ototoxicity, or with ethambutol, if they feel that there is any symptoms of visual disturbance, we tell them, even if you cannot contact us, just stop the drug and get in touch with one of us immediately. Right? So this is something that I feel very, very strongly about. I cannot tell you how many patients we've had who've developed disabling side effects of anti-tubercular drugs. So this is something that we have to incorporate in our practice. And just one slide on resistant TB. Dr. Agashe really has covered this so brilliantly. But this is how your patient will first come to you with evidence of resistant TB. You will have a gene expert MTB detected and RIF resistance detected. This is the first indication that you will have that this patient has resistant TB, because really this test comes in first. The RIF resistance is a surrogate for drug-resistant TB, and it indicates in most cases that isoniazid, ethambutol, and pyrazinamide will also be resistant. In these cases, further testing with the line probe assay, TB midget culture is essential. There is no question about it. TB midget 14 drug DST is essential if you see RIF resistance detected. You have to involve the expertise of a physician, an ID person, pulmonologist, somebody who's familiar with treating resistant TB. It's important to remember now that the newer drugs, which most of these patients are sort of entitled to, bedaquiline, delaminate, are available only at government DR TB centers. They are not available in the private market, in the private pharmacies. And so please encourage your patients with drug-resistant TB to enroll themselves at a government center, because this is where they get the best follow-up. This is where the drugs are taken care of for free. The government has really woken up to drug-resistant TB, and they're doing a brilliant job of it. So a lot of my patients who insist on the close monitoring of a private setup and the ability to communicate with a private doctor and everything, come to me for their follow-ups. I sort of look through all their drugs, look at all their side effects, manage the durations and everything, but they still get their medication from the government center, because drugs like bedaquiline and delaminate are not given anywhere else. So with that, I'm going to stop and just take questions regarding anti-tubercular treatment.
Before you take questions, Aisha, great talk. Great talk. Before you take questions, you have given me a very important input as regards the shoulder case is concerned. So if you could just explain that.
Yeah, I meant to come to that. So actually, this is the first time I saw that case when Aditya, I never knew that you all had this case. Remember, in a child who presents with an abscess in the shoulder, which turns out to be TB, your first differential should be, or your first question should be about BCG. What happened to the BCG? What happened to the scar? Did the child ever develop an abnormal swelling over the BCG scar? Was it purulent? And that gives you an idea that this may be a BCGoma or BCGosis that is infected, and then further, development of osteoarticular TB from that. And a very, very important point here is that the hallmark of a BCG related infection, BCG is not Mycobacterium tuberculosis. BCG is Mycobacterium bovis. It is part of the MTB complex, but BCG is made from Mycobacterium bovis. And the hallmark clinical evidence of Mycobacterium bovis is that it will be pyrazinamide monoresistant. All the other drugs will be sensitive. Pyrazinamide will be monoresistant. So whenever you see a case of pyrazinamide monoresistance, think of a BCGosis, BCGoma. Think of a patient who's had a bladder cancer and received BCG installation. These are the kind of patients in whom we see it, and we're dealing with Mycobacterium bovis. I also pointed out to Aditya that in a case like that, I mean, you see BCGomas, you see an abscess, child takes a little longer for it to heal, and that's fine. But a child that develops, sort of a large abscess, which goes on to then develop osteomyelitis of the area, is a child that needs to be worked up for, as somebody pointed out, genetic susceptibility, Mendelian susceptibility to mycobacterial disease.
Thank you. Thank you. Now, talks are open for questions.
Ma'am, question. May I ask if after stopping isoniazid or rifampin because of jaundice or hepatotoxicity, what happens from that point? Will we restart when the jaundice disappears and the liver enzymes normalize, or will change the medication to another one?
Okay. So this was very simply taught to me by my mentor, Dr. Soman. All right. We look at our TB patients as patients with life-threatening tuberculosis, people who have TB meningitis, disseminated TB, pericardial TB, all right, and people who don't have life-threatening tuberculosis, all right. So you see your lymph node, pulmonary, extrapulmonary, chronic sort of, bone and joint TB and things like that. In patients who develop hepatotoxicity, you're on your first line drugs. You know that 3 of these drugs can cause hepatotoxicity. There is a simple rule. If the patient is asymptomatic, but the liver enzymes are more than 5 times the upper limit of normal, that indicates significant hepatotoxicity. Or if your patients are symptomatic, they're anorexic, they're nauseous, they have some dyspepsia, and their liver enzymes are more than 3 times the upper limit of normal, that also constitutes hepatotoxicity. In patients like this, who do not have life-threatening TB, what we can do is we could stop all 3 first-line drugs. We just continue with ethambutol. Every 72 hours, we repeat an LFT and we add in 1 drug. All right. So we restart with, say, isoniazid, and then watch for another 3 days. So you wait for the LFTs to come down below 3 times the upper limit of normal. You can see that it's downtrending. You'll throw in 1 drug. Then you call them back with an LFT after 72 hours and see what's happened. And you repeat this process until you come to the culprit drug. And that indicates to you which drug is the culprit drug. Once you've identified the culprit drug, you knock that off your 4-drug regimen. There are 2 schools of thought. One which feels that you could reintroduce it after some time, and some patients may tolerate it. Another school of thought feels that if a drug has caused hepatotoxicity on a recommended, weight-based AKT regimen, it's not worth throwing it in again. and you'd substitute this drug for another drug from the second line regimen. Does that answer your question?
Yes, ma'am. Thank you. Thank you very much, ma'am.
Sure. And on the other hand, if you have life-threatening TB and you cannot stop the drugs, all right, then you would temporarily substitute them with second line drugs until you can follow the same process of checking every few days and seeing which your culprit drug was, and then reintroducing first line drugs slowly.
Thank you, ma'am.
Sure.
Thank you, Dr. Ayesha. If there are no more questions, I think we can wrap up and call it a day. What we will do is we may share the basics of bacteriology, which we had discussed in the previous session, as a PDF, so people can refer to it. We'll share it on the WhatsApp group. We can do that.
So Dr. Thakur can.
Dr. Menon, can I?
Yeah, go ahead.
Of course.
A few moments. Yeah, I think thanks, Dr. Ayesha. It was an excellent deliberation. Couple of points. Our learnings from Hansen's disease proves that rifampicin given alone separately works better. So that is a learning from Hansen's, which we have probably forgotten because we're not dealing with Hansen's anymore. The other thing about the RNTCP, does it allow a pyrazinamide in the continuation phase? Do we have any option of doing that? That would be my second question. And
so as the
please.
Go ahead. Let's take both.
2 more points you can choose to answer. The linezolid thing, I am very worried. I feel very worried when I see linezolid being used rampantly. I mean, how can we stop linezolid being used as a post-operative antibiotic, or in pediatric age groups, pediatrician writing linezolid? They think it's a very safe antibiotic. And I keep on saying that it's a second line antitubercular drug and I would not use it. So this is a fight going on, and how can we handle that? And last point is this Nikakshay that you said has got a medico-legal significance. I think doctors should know that it's not medico-legally bound that you have to report tuberculosis. If you don't, you're liable to be imprisoned also. So this message also has to go forward. Thank you. Thank you. These are not questions, just comments. You can choose to answer whatever. Thank you.
So yes, you're right. Pyrazinamide is not currently part of the program as, within the continuation phase. And again, these are gray areas. In the private setting, we do choose to sometimes, do it differently, especially when we feel that there would be an advantage of continuing pyrazinamide in the continuation phase, as I said, in patients with large abscesses, tuberculomas, large paravertebral, abscesses, where we know that pyrazinamide really penetrates into the space very well. Of course, this goes without saying that you have to ensure then that you have explained side effects to the patients, you have discussed why you are continuing this drug with the patients, and you are able to maintain a close enough follow-up with your patients, right? And you give them access to get in touch with you if there is anything wrong. So, you sort of discussed with them at what time intervals they will do certain laboratory tests and get back to you and everything. So this is something that we've done routinely. We've had success with it. And if you've gotten away with pyrazinamide for 2 months without any serious toxicity, I really haven't seen pyrazinamide causing significant toxicity, even in the continuation phase, even when it's continued for longer. In fact, in some of our TB meningitis patients, drug-resistant TB meningitis patients, especially in whom, you have a pyrazinamide susceptible or whatever, we've used it for 2 and 2.5 years. So that's one. Secondly, about linezolid. Yeah, linezolid, I couldn't agree with you more. And that goes with, without saying, with regards to multiple other drugs that we are abusing, on other fronts. But linezolid particularly, because it forms such an important armamentarium, second line armamentarium. It also has excellent CNS penetration. So yes, I couldn't agree with you more that we probably aren't doing enough to stop the misuse of this very, very important drug, especially in the community and in pediatric practice and everything. And yes, finally, that's what I try to bring out through Nikshay, that it's something that the government needs to be applauded for, and it does have medical legal implications, which we have to take seriously. So my patients actually tell me about it like it's nuisance value. They keep saying, government people keep calling us and asking us what's happening with our treatment and stuff. They keep saying, you're going to have to comply with them. Please cooperate and tell them everything that's happening, because this is for the greater good of the community.
Thank you, Dr. Ayesha, for the summary. And I got some pleasure there after I heard Dr. Suranjan saying that a surgeon was requesting the physicians and the pediatricians to stop certain antibiotics. So there was a sadistic pleasure there with an ID physician with us. So, Thakur sir, if we could request you to summarize today's session.
Sure. I would summarize the entire session in one word: beware. We started with that slogan to start with, and then we came up under several places where we need to be aware of what we are doing. Right in the beginning, when Dr. Agashe surveyed answered the survey, it was very heartening to know that 70% of the participants follow culture and tissue diagnosis and then only start tuberculosis, which is very, very encouraging, because all these years, particularly in my time of residency and early consultancy, we would smell tuberculosis and start anti-tubercular drug, which was then only streptomycin, Isonex, and this thing. So things are changing, and we got to change because of the so many bewares that have been given. I entirely agree that we have to change our vocabulary from diagnosing to impression. We can't say looking at the MRI and history is that it is tuberculosis. We can only say, I think it is tuberculosis, but I will like to prove it by doing other things, and which is culture and sensitivity. Exceptions are of course there, and we have to be aware and start anti-tubercular drug on very strong suspicion, or when we run out of other things, we should help the patient by doing this thing. When it comes to non-respondents, I think orthopedic surgeons to say, this is it, this is my Lakshman Resha, and I'm going to go to somebody like Dr. Soonawala or Dr. Soman or somebody like this. The complexities of the drug, we were faintly aware, but after today's talk by Dr. Soonawala, I would be very scared to start even a single drug. I would always involve my physicians, friends, to get into the show and take the burden off me. When it comes to drug resistance, this is a new concept altogether. All these years, at least I used to think that you give the 4 drugs and that's it, your responsibility is over. But now more and more drug resistance is coming up into picture, and we all got to be very aware. HIV was a really go-to thing. Anything went wrong, we say it is HIV and that's why it is happening. But we are now understanding that the initial infection could be from a tubercular bacillus which is resistant to all the 14 drugs. And that is really scary. That is going back to time even before Robert Koch discovered the bacilli. So it's really putting us back, and we should be worried about the patients who come with primary resistant infection. Of course, acquired resistance is partly because of us, because we do not inculcate enough discipline in our patients, or we do not follow them up as vigorously as we should. I'm talking of private sector. I have no idea what happens into the government sector. But both the sectors must come together and follow up their patients, or at least make them aware that if they don't stick to the regime, if they don't keep in touch with the doctor, they have a really hard time to go with. BOS really did a good job, and I have to congratulate Dr. Agashi and his team to really persevere over 7 years. Easy part was for BOS to grant money, and I was one of the guys who was responsible for granting money. But that was the easy part. The tough part was done by the team at Hinduja, and we are very proud to be associated with that study. For the first time, we understood what is MDR and XDR, and these things exist. So Dr. Agashi has done a lot of awakening thing and behavioring thing for everything. It is really worrisome that resistant patterns are worsening. This is a very serious situation, and I'm glad government is doing a lot for this. Then we had this shoulder case, and which was to start with was very disturbing. Why should a 9-month-old fellow get a tuberculosis like this? But at the end, in the question answer session, we came to know that it could be following a BCG infection. And that was enlightening, and that was very essential, good to know. After shoulder case, we had this elbow cases, which were again gave us a guideline how to treat tuberculosis in the joints all over, upper limb or lower limb both. If there is synovial, earlier thing you could do non-surgical. If it is more involved, whether it's grade 2, 3A or 3B or whatever, or do the surgery. And when it is all fired up, which is now rare these days, but you still have to do the surgery, but do not promise patient anything good. Foot was again very enlightening. Many times we give so many other reasons for the discharging sinus, but do not apply MRI or repeated X-rays, and perseverance does things. After those orthopedic discussions, then we had really eye-openers and beware things from Dr. Aisha. Again, she told us about deteriorating susceptibility to drugs, which was again very frightening to me. And all her rundowns on the standard drug treatment and all the guidance for managing patients, etc., were very, very informative. And I would like to inculcate that patient sheet that she showed to be given to every patient, and ask him to approach the doctor or the physician when there are chances of getting resistance or side effects is very, very important, and we would like to do that again. So overall, it was a very bewailing session for all of us, very informative, made us more sensitive to our diagnosis of tuberculosis and more sensitive towards starting anti-tubercular drugs on our own without the help of physician. We should not be doing that. We should always get on with the physician and then treat the patient jointly rather than do it ourselves. I think that includes everything that we discussed this evening.
Thank you, sir. Thank you very much.
Thank you.
Thank you. Bye-bye. Bye, everybody.
Bye-bye.
We will be meeting on 7th with Dr. Darvi, and it would be essentially spinal tuberculosis, related to spinal tuberculosis. Am I right, Dr. Menon?
Yes, sir. Spinal tuberculosis. And,
So
and before we sign, yes, sir.
The date is confirmed or?
Yes, 7th.
Confirmed. Okay. Okay.
The timing is same, isn't it?
Yes.
Yes.
The timing is same.
Okay, fine.
And before we sign off, I would just like to add one more point. I mean, COVID has brought us technologically together. We are sitting on a Zoom platform in different parts of the world in India. People who say that they don't have access to an ID physician or a chest physician because of the center or city, I think now they're all available across teleconsulting platforms, across a WhatsApp video call. Every person in India and abroad has a phone and a data network, and it's easily available. So I think all of us should start thinking on those lines. Even our patients actually teleconsult with Dr. Aisha, Dr. Umang. They don't necessarily have to come physically. So world has become smaller that way. So let's make use of it.
Correct.
Correctly.
Absolutely right. Okay. Bye-bye, everybody.
Bye, sir. Thank you.
See you on
Bye-bye.
7th.
Bye.
See you on 7th. Bye. Bye.
Bye.